Hello, welcome to webinar number 9 about COVID-19, brought to you by New York Medical College of the Touro College and University System. As it has been for all of these webinars, I'm your host, Edward Halprin, the Provost for Biomedical Affairs of the Touro College and University System, and the Chancellor and CEO of New York Medical College. This is our 9th webinar and our 1-year anniversary. We gave our first program in January of last year. But this is surely no time for an anniversary celebration, is it? Hundreds of thousands of deaths in the United States, many-fold more throughout the world, a pandemic which continues to rage, and a very troublesome 2020. Besides the pandemic, violence from extrajudicial murders of Breonna Taylor and George Floyd and others, demonstrations, a difficult and contested presidential election, a second election recently in Georgia, and now mob violence in the nation's capital. Let us all pray for a better year ahead. And what we at Touro and New York Medical College can do to help is, as we've done in the past, to the best we can, to provide you with up-to-date, useful information to help you and your patients navigate the pandemic. For today's program, we're going to have some old friends and some new friends, some people you've grown to get used to from our webinars, and some new faces, with some new topics based on your recommendations from previous webinars about what you wanted to see in today's webinars. You're going to, once again, see an old friend, Dr. Alan Kadish, the president of the Touro College and University System, to welcome you and make some opening remarks and to moderate our question and answer session. You're going to meet Dr. Stephen Ferrando, the chairman of psychiatry at New York Medical College and Westchester Medical Center, who's going to talk about helping to take care of yourself, how to be resilient during the pandemic. You'll hear again from an old friend, Dr. Marissa Montecalvo, who's going to talk to us about COVID-19 cocktails and whether they're useful for the treatment of the disease. And then we're going to spend a lot of time on the vaccine. Dr. Robert Amler will be back to talk to you about the logistics of administering large-scale vaccination programs. We're going to hear from Professor Lisa Kasdan and from me about the ethics of the administration of vaccines. An old friend from these programs, Dr. Kathleen DiCaprio, will be back to go over the most commonly asked questions about the vaccine. And then Dr. Karen Murray, who's been with us before, will focus particularly on the problems of pregnancy and expected pregnancy and breastfeeding and the administration of the vaccine. Now remember, if you have questions during the program, be sure to type those questions in at the question and answer function on your screen. We'll be monitoring them and parsing them out to our speakers as time allows during the Q&A period. And I'll be back to see you during this program to tell you about how to get your CME credit. So watch for the commercial interruptions for CME credit, and also periodically to ask you to consider helping to support these programs. So now let's go to Dr. Alan Kadish to welcome you to the program, and you'll be hearing from me again with information about CME and how to support the college during the program. I wish you an enjoyable, interesting, and productive program. Dr. Kadish, you have the floor.
Welcome to the 9th New York Medical College Touro webinar on the COVID-19 pandemic. I'm Dr. Alan Kadish, president of Touro College and president of New York Medical College. It's a pleasure to have you with us today, although we hope that at some point we'll reach the last webinar. I want to begin by showing you a bit about where we are today, and really it's a combination of two stories. Our first webinar at the end of January happened well before there were new cases in the United States, and things seemed under control in the late spring, or at least not accelerating, But as you know, there was a bump in the summer, and now we've hit an all-time high in new cases. The death rate doesn't appear to be as high as it was, but hospitalizations, given this record number of new cases, are also at a record in the United States. And in some states, positive test levels, an indication of how much infection is going on, are really, really high. So that's the bad news. The good news spans a couple of areas. One, as I mentioned, the death rate has been decreasing, and that's likely because we've gotten better at treating COVID. While single drug therapy has not produced any dramatic results, there's evidence that some drugs could help a little bit, and that antibody therapy may work, particularly when given early. And we'll talk a little bit about that today. The second piece of good news, of course, is vaccines. It's no secret the vaccine rollout in the United States hasn't gone quite the way we had hoped. However, the fact is, vaccine administration is accelerating, and I believe we're near the point where vaccines will make a difference in the public health outcome. There have been several controversies about the vaccine rollout. One, why is it taking so long? Two, how is it being fairly distributed? Three, who's getting it and who's not? And four, are there special populations, such as pregnant women, where there are different considerations regarding vaccines? We'll try to address all of those issues today. So we're at an interesting touch point. Records number of cases, some improvements in therapy, vaccines coming on board, and, as we'll hear a little bit about today, new mutations in the COVID-19 virus, SARS coronavirus, whose significance we're still unclear about. If you're able to distance yourself from the terrible human tragedy that's accompanied the COVID-19 pandemic, illness, death, poverty, economic deprivation, unemployment, if you can isolate yourself from those for just a moment, it's been a fascinating scientific experience. We're still learning, but with the advent of targeted therapy and the advent of vaccine therapy, we're rapidly approaching the point where scientific advances have made a significant therapeutic impact. Let's talk about it, and welcome. Thank you.
Hello, this is Dr. Edward Halpern, your host, back to tell you about how to get your continuing medical education credit for today's program. The program offers up to 1.5 hours of CME credit, and there's two ways to get your CME credit. You can send a text message to 828-295-1144 and type in 92BIKE, BIKE, 92BIKE, all in capitals. And if you send that message to that phone number, you'll get a quick response with instructions as to how to get your CME credit and how to fill out your satisfaction questionnaire. If you don't like doing it that way, you can use your search engine, type in www.eeds.com, and up will pop our website. Click on the sign-in button. Once again, enter the code 92BIKE. And once again, you'll get instructions as to how to get your CME and how to fill out your satisfaction questionnaire. Now, these ways of getting your CME will be active until the end of the week, Friday, January 15th at 3 o'clock. So please write down these instructions or take a screenshot or take a picture with your cell phone so you can get your CME credit. Also remember, as the program continues today, if you have a question for any of our speakers, go to the question and answer function on your screen, type in your question, and we're monitoring them. And we will monitor them and parse them out to our speakers so they can answer as many of your questions as possible during the program. And now back to our program.
Hi, everyone. This is Dr. Steve Ferrando. I'm professor and chairman of psychiatry at New York Medical College and director of psychiatry at Westchester Medical Center. Today, I'm going to be speaking with you about self-care of healthcare providers during the pandemic, being resilient when your world seems to be crashing around you. For the purposes of this talk, I have no conflicts of interest to disclose. So let's get right into it. What is resilience? Well, someone has said that resilience is that ineffable quality that allows some people to be knocked down by life and come back stronger than ever. In psychology, this is not a new concept. The concept is based on the notion of adaptation to trauma throughout the life cycle. Suffice it to say that there are inborn heritable elements, but resilience can be learned or acquired, and that's good news. Resilience for healthcare workers during COVID-19 is exceedingly important. Why? Because obviously healthcare workers have been on the front line and subject to recurrent and sustained trauma during the pandemic. If we don't have resilience, we can become burned out. What is burnout? According to WHO, it's feelings of energy depletion or exhaustion, increased mental distance or detachment from one's job, feelings of negativism or cynicism related to one's job, and reduced professional efficacy. In short, in my mind, it's loss of positive meaning to our work. Positive meaning is what we need in order to help sustain us. While burnout may influence health and mental health, WHO says that it's not actually classified as a medical condition or a mental disorder, but it can lead to one. One study indicates that about a third of healthcare workers during COVID-19 reported symptoms of PTSD, while 1 in 5 reported significant symptoms of anxiety and depression. Among our healthcare workers, we did a survey of their levels of distress and some of the predictors of their level of distress during the first wave of the COVID-19 pandemic. I'll share with you some of the data here. On the top left is an assessment of healthcare workers' distress before the pandemic, and on the bottom right, is distress during the height of the pandemic, particularly in the first wave. And what you can see is that levels of moderate to severe distress went from about 20%, indicated by the yellow and green areas on the slide, prior to the pandemic, to over 75% during the pandemic, experiencing moderate to severe distress. What types of distress? Not surprisingly, the most common ones were anxiety and insomnia, while depressed mood and physical symptomatology was present in a significant minority of individuals. So given this level of distress, how do we cope? What are what we call maladaptive, bad, and adaptive, good mechanisms of coping? Well, very basically, maladaptive coping, or negative coping, if you will, is most associated with a passive avoidant coping style, while adaptive coping is most associated with active engaged coping. So passive avoidant coping, isolation and social withdrawal, denial, remaining sedentary, over or under eating, using alcohol or drugs to avoid, deny, or self-medicate pain to an excessive amount, and resorting to negative thinking. Most importantly, cynicism and hopelessness. Adaptive coping strategies that we need to cultivate in ourselves, including in socialization and support. This is very, very important, staying in touch with family and friends, sometimes despite quarantining and shutdowns. Maintaining mindfulness, a non-judgmental sense of what's going on in the present and how you can move forward without self-criticism or criticizing the world. Maintaining healthy exercise and diet are very important, and of course, moderation in any use of alcohol or other types of substances. And finally, employing meaning-based coping. And for us, that means maintaining hope and a sense of meaning in what we're doing, no matter how difficult it is at any given time. And importantly, spiritual-based coping, which can be very different for different individuals. But suffice it to say that these two elements are highly correlated with adaptation and decreased distress during pandemic and other times of stress. So these are just a few pointers. I hope they're useful. And if you have any further questions, please feel free to speak up. Thank you.
Good afternoon. I'm Marissa Montecalvo, and I'm going to be speaking on Shall We Serve Antibody Cocktails to COVID-19 Patients. I have no conflicts of interest to disclose. So in thinking about antibody cocktails and monoclonal antibodies, I just want to say a word about treatment in general. So when we treat SARS coronavirus 2, we're looking early on at blocking replication, either by use of an antibody, which can block the adhesion of the virus to the receptor. And that has been done with convalescent plasma, antibodies from there, and now with monoclonal and polyclonal antibodies, and then to block viral replication. As disease progresses, as you see in this radiograph of bilateral pneumonia early on in the pandemic, the most important thing there is blocking the exaggerated inflammation associated with the progression of disease, and that's the role of dexamethasone. So there are three major groups with treatment guidelines: WHO, NIH, and Infectious Disease Society of America. I projected NIH and IDSA here. And as you look at these treatment guidelines, they are grouped according to disease severity. And I'll start at the bottom with the most severe disease. So that's where it's clear, dexamethasone. And IDSA also recommends remdesivir. As we go up and you have patients on oxygen with non-invasive ventilation or just requiring supplemental oxygen, that's the role of remdesivir. And then depending upon how sick they are, with or without dexamethasone. But it's the first group, those with mild to moderate disease, 80% of whom will do well without any treatment, is the group that is being considered for these monoclonal antibodies to treat them early on. And the key is to try to find who are those patients who would be at risk for more severe disease. So if we look at the immune response to SARS-CoV-2, and this is a relatively old slide at this point, but is still very important. It shows antibody production over time. And you can see that over the first 5 to 7 days, you don't have any antibody. So this is the key moment in which an antibody administered to you would be beneficial. So we now have antibodies that can be produced that are have anti-spike neutralizing antibody and will bind the spike protein, and so it does not link to the receptor on the lung. 2 of these are under emergency use authorization, authorized for non-hospitalized patients with mild to moderate disease and at risk for severe disease. And those 2 drugs, bamlanivimab and casirivimab, plus indevimab, which is the polyclonal antibody that the president received, both received their emergency use authorizations in November. I'm going to show you the data regarding bamlanivimab first, because that actually has a published clinical trial that came out in the New England Journal. So this was a phase 2 trial with 4 arms in the study, 452 patients equally divided between placebo, 700, 2,800, and 7,000 milligram treatments. There were patients with mild to moderate disease treated within 4 days of symptom onset, with the primary endpoint being the reduction in viral load as measured by nasopharyngeal PCR. They also looked at hospitalizations and clinical improvement. The average age was 45, and a large group of patients were overweight. So as you look at this, if you look at reduction in viral load in the placebo arm, there was a reduction in viral load, and you would expect this because that's the natural history of this disease. Your viral load is highest at the beginning and is then going down over the next 10 days. And only in the 2,800 milligram arm was there a reduction that was significantly better than placebo. Secondary outcomes, there was less hospitalization among those that were treated. However, the groups were small and it was not enough to achieve statistical significance. And what was learned was that this intravenous treatment was well tolerated with some immediate infusion reactions. If we look at casirivimab plus imdevimab, this has not been published yet, but there is a phase 2 study, very similar, treated at day 3 instead of day 4, but very similar design. And again, with the primary outcome being reduction in viral load, which was significantly less in those who were treated versus the placebo group. So these are the at-risk criteria. So we're looking at people with mild to moderate disease at risk for severe disease. And under the emergency use authorization, the at-risk criteria are the same for the 2 drugs. For persons over 12, BMI over 35, chronic kidney disease, diabetes, immunosuppressive treatment or disease. If you're over 65 and have mild to moderate disease, that's enough to qualify. If you're over 55, cardiovascular, hypertension, or chronic obstructive pulmonary disease. And the criteria for children are listed below. So in answer to, shall we serve antibody cocktails to COVID-19 patients? Well, the current data can't really support a strong recommendation. I mean, there's the BLAZE study with one group actually having a more significant reduction. And it's hard because, as I mentioned before, the natural history is for viral load to go down. So this will take further study to really determine whether there are reductions in hospitalizations and in the development of severe COVID. However, conceptually, this is a treatment that is extremely appealing. Giving antibodies to persons at risk is something that is done in other viral infectious diseases. And there may be other groups for which this could be beneficial. It could be that this could be important as post-exposure prophylaxis. However, the hard part is that we're dealing with a disease that's so widespread. And the number 4, I projected the data from China back in February of how the percentage of people with moderate, severe, and critical disease, and still 81% have mild disease. So the question is, who's really at risk for severe disease within that mild group? And that is the place that these antibodies are being targeted. And of course, cost and the need for intravenous infusion is also something that has to be considered as we move forward with these treatments. Thank you very much.
Programs like you're listening to today provide you with continuing medical education credits for free. But it is, of course, not free to New York Medical College to put on these programs. How can you help? Well, programs like you're listening to today and our COVID-19 research projects require time, effort, and funds. I hope you'll consider making a tax-deductible gift, and your donation will help offset our costs because great things are happening at New York Medical College. There's a couple of ways you could make your donation. To make your gift, you could phone 914-594-2720, and we'll take the information for a gift. You could go online to www.nymc.edu/give and make a donation online. And for those of you who, like me, like to take a pen and write out a check, We'll be more than happy to take a check made out to New York Medical College and mailed to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York. Thanks for thinking of us during these challenging times, and stay safe and healthy.
Hello, I'm Dr. Robert Amler. When it comes to large-scale vaccination logistics, compliance is always an issue. I have no conflicts to disclose. Well, what determines compliance? It's perception, emotions, and social factors. Perception includes the perceived benefits and the perceived risks of a vaccine. Emotions include suspicion or fear of what you're going to take, and trust, the confidence that you have in what you're going to take. The social factor is something we always see. Are you going to run with the herd, or are you going to go against the tide of your friends and family and peers? Consider these determinants and how they play out differently between medications and vaccines, because they are really very different. When we look at benefits, when there's a medication offered, well, I'm sick, I need this now. The benefit is obvious and immediate. When it comes to vaccine, though, the benefit is only maybe I won't get sick someday. It's not as immediate. But I'm not sick now, so maybe I don't really need this. And that will factor into the benefit perception of the person getting vaccinated. When we look at risks for medication, sure, we worry about side effects. Maybe taking it every day is inconvenient. And if it's a new medication, we might be a little concerned. But with vaccination, there's an immediate risk of a jab in your arm and pain and the inconvenience of having to leave where you are and go someplace to get vaccinated. And of course, you still worry about side effects, particularly for something new. There's suspicion. Even with medication, you do kind of worry, is this the right drug? Is it the correct dose? But with vaccine, you really don't know. What is this stuff? Is it poison? How bad could this be? When it comes to trust, you generally will trust your doctor, your pharmacist, because your doctor and your pharmacist know you and they care. But the CDC and the FDA send you the vaccine. What do they know about you? Who are they? Do they really care about you? So there's less trust with a vaccine. And the old herd motivation. People around you take this medication. Everyone says it's great, at least when the drug first comes out. But with vaccine, there's a lot more hearsay going around. And many people you offer the vaccine will say, well, I heard things. I'm not so sure. Through all these doubts, though, the principal concept is this. A vaccine is a kind of medication for which the benefits outweigh the risks so overwhelmingly that it's recommended for nearly everyone. Remember, this vaccine against COVID is absolutely essential. So how shall we address vaccine hesitancy, which is natural and always present? First, it's best to avoid direct confrontation. That almost never works. It's important to listen to someone's concerns, acknowledge those concerns, and own those concerns, and think the problem through with them. Separate the real risks for infection with wild virus from the hypotheticals and the maybes of what could possibly happen. There are real risks versus hypotheticals. Go with the real risks and take the right action. Explain the benefits and the review process for the vaccine. Explain secondary benefits, which include getting our handle on this virus and being able to get back to normal sooner, which is what everybody wants. But reassurance demands verification by us. If we are going to reassure our clients, our patients, we need to be absolutely sure professionally and ethically that we're giving them the right advice. So this system, which was actually developed by my team at CDC in the early 1980s, The vaccine adverse event reporting system is monitored by CDC and FDA. It mandates reporting by clinicians and manufacturers. It takes voluntary reports from anyone who wants to send it in. Just go to that website. And any clinically important medical event or health problem is recorded. Creates a nationwide registry for data analysis, which identifies clusters or high-risk groups if they occur. So when it comes to large-scale vaccination logistics, hesitancy and compliance are just one issue of many, and there will be more to follow as 2021 unfolds. Thank you.
Good afternoon. My name is Lila Kajdan, and I'm the Director of Medical Ethics for the School of Medicine at New York Medical College. From whence does it come that governments have the ability to inform health decisions or control health behaviors for the individual? From whence does it come that governments have the ability to advise, insist, or mandate vaccines for individuals or populations? What is the history of vaccine mandates, and when can mandates be invoked? In 1796, Edward Jenner determined that inoculation with material from a cowpox lesion would protect against subsequent exposure to smallpox. This ushered in the era of vaccinations. The Centers for Disease Control and Prevention declared vaccinations to be one of the 10 greatest public health achievements of the 20th century. Vaccines are responsible for many public health successes, such as the eradication of smallpox and reductions in other serious infections like polio and measles. That said, vaccinations have also been the subject of various ethical controversies. The ethical debates related to vaccine regulation development and use typically revolve around mandates, research and testing, informed consent, and access disparities. And the development of the smallpox vaccine triggered the establishment of vaccination mandates, especially for children. Then, as the incidence of smallpox declined over time, some governments loosened requirements while others mandated remained in place. As noted in CDC archives, the judicial branch of the US federal government has had a role in vaccination. A variety of court decisions have considered the validity of vaccination mandates and have attempted to address the conflict between individual rights and protection of the public's health. The ethical issues surround individual autonomy and concern for the collective, an issue of concern in public health more broadly. It forces us to ask about government's control of the health behaviors of its citizens. These questions are not limited to the area of vaccinations exclusively. For example, in 1927, the US Supreme Court case Buck versus Bell set a legal precedent that states may sterilize inmates of public institutions. The court argued that imbecility, epilepsy, and feeble-mindedness are hereditary, and that inmates should be prevented from passing these defects to the next generation. The practice was ended nationwide in the 1970s. How did the power of the state to require vaccination develop as a concept? In the United States, state policies mandate certain immunizations, including school admission requirements. The first school vaccination requirements were enacted in the 1850s to prevent smallpox. Federal and state efforts to eradicate measles in the 1960s motivated many mandate policies as well. And by the 1990s, all 50 states required students to receive certain immunizations. Vaccines are licensed and added to the immunization schedule after research and testing. And then states devise mandates according to this body of knowledge on a state-by-state level. Ethical debates and objections to mandates arise because some individuals and communities disagree with the mandates, or have religious or philosophical beliefs that conflict with vaccination. For example, in an effort to protect the greatest number of people, public health vaccine regulations may infringe upon individual autonomy and liberty. Occasionally, vaccine mandate controversies include multiple ethical dilemmas. This is the case for the vaccine for the human papilloma virus, HPV, a sexually transmitted disease. The FDA approved the first HPV vaccine in 2006, and soon after its approval, state legislatures attempted to mandate vaccination. Ethical objections to this mandate have ranged to include religious concerns. All 50 states allow vaccination exemptions for medical contraindications to address individuals' beliefs and their varied concerns about vaccination. Many scientific and medical research studies have found that individuals who exercise religious or philosophical exemptions are at a greater risk of contracting infections, which put themselves and their communities at risk. And thus, medical and public health advocates often struggle to balance the ethics of protecting individual beliefs and the community's health. So when can mandating vaccines be invoked? Essentially, when there is a public health emergency and for the common good, as well as for the benefit of public safety. The first state law mandating vaccination was enacted in Massachusetts in 1809. In 1855, Massachusetts became the first state to enact a school vaccination requirement. The constitutional basis of vaccination requirements rests in the police power of the state. More than 100 years ago, the US Supreme Court issued its ruling in Jacobson versus Massachusetts, upholding the right of states to compel vaccination. The court held that a health regulation requiring smallpox vaccination was a reasonable exercise of the state's police power and did not violate the liberty rights of individuals under the 14th Amendment to the US Constitution. The police power is the authority reserved to the states by the Constitution and embraces, open quote, such reasonable regulations established directly by legislative enactment as will protect the public health and the public safety, close quote. In the case of Jacobson, the Commonwealth of Massachusetts had enacted a statute that authorized local boards of health to require vaccination. Jacobson refused to be vaccinated against smallpox as required by regulations of the Cambridge Board of Health. While acknowledging the potential for vaccines to cause negative side effects and the difficulty to prove with absolute certainty whether a particular person can be safely vaccinated, the court rejected the idea of an exemption based on personal choice. To do otherwise, the court said, would practically strip the legislative department of its function to care for the public health and the public safety when endangered by epidemics of disease. The court further explained this tension between personal freedom and public health inherent in liberty. Open quote, the liberty secured by the Constitution of the United States to every person within its jurisdiction does not import an absolute right in each person at all times and in all circumstances, wholly freed from restraint. There are manifold restraints to which each person is necessarily subject for the common good. On any other basis, organized society could not exist with safety for its members. Although vaccines are safe and effective, they are not perfectly safe, nor are they perfectly effective. Some individuals have medical conditions that put them at risk and should not receive vaccines. Recognizing this fact, all state vaccination laws provide for exemptions for persons with contraindicating conditions. The religious beliefs or philosophy of an individual as well play a part for exemptions. And some people are opposed to simply the concept of mandatory vaccination or mandates for vaccines. Challenges to mandatory vaccination laws based on religion or philosophic belief have led various courts to hold that no constitutional right exists to either religious or philosophic exemptions. Additionally, the vaccine mandate conversation has centered around liberty and self-determination. The general concept of a liberty claim in bodily integrity was first articulated by Justice Cardozo in Schlondorf versus Society of New York Hospital. Every human being of adult years and sound mind has a right to determine what shall be done with his own body regarding medical needs. He says, recognition by the courts in recent years of a liberty right or privacy right in medical decision-making might be used as the basis of a claimed privacy right by an individual subject to mandatory vaccination. However, the court noted that the medical privacy right is not unlimited and must be balanced against important state interests and regulation. The US Supreme Court concluded that as long as the public health need for widespread vaccination exists, the courts will not recognize a privacy right to refuse state mandated vaccination and will uphold the police power of states to mandate vaccination. Overall, vaccine acceptance for pediatrics is very high, but in adult populations, it proves to be more variable. A recent JAMA article reads, legal mandates signal clear policy support for immunizations, which can also increase resources for a vaccine infrastructure. Yet mandates can undermine public support, creating a backlash and even reducing vaccine uptake. Mandates may be useful in the future, but their implementation among any population that does not widely support vaccination could be counterproductive. Though, since Jacobson versus Massachusetts in 1905, the judiciary has consistently upheld vaccination mandates in institutions that can enforce them. Given the rarity of adult mandates, states are unlikely to enact mandatory COVID-19 vaccinations for the adult population. It is likely then that those individuals who refuse to wear masks will also refuse to receive a vaccine, perhaps even more so. Thank you.
I'm going to speak with you about the ethics of the allocation of scarce healthcare resources and the applicability of this issue to the COVID-19 vaccine. My name is Edward Halprin. I'm the Provost for Biomedical Affairs of Touro and the Chancellor and CEO of New York Medical College. I have no conflicts of interest to declare. The problem that we now face as a society is, where do you get in line for the vaccine? Do you get in the front or the middle or the back of the line as we prioritize the order in which the COVID-19 vaccine is administered? I began to first encounter problems like this of medical ethics when I was a resident. I worked under the tutelage of a famous radiation oncologist, C.C. Wang. Dr. Wang was a professor at Harvard Medical School and an attending radiation oncologist at the Massachusetts General Hospital. When I expressed an interest in medical ethics as a resident, he would harumph at me and say, "I don't know what the point is of teaching courses in medical ethics. Medical ethics is just common sense." When I was a radiation oncology resident in the early 1980s, and Dr. Wang said that, I knew he was wrong. The problem was, it took me more than 30 years of clinical practice to figure out precisely why he was wrong. And I came to realize the problem is not getting a system of ethics to make sense. Lots of ethical systems can be constructed to have an internally consistent logic. The real problem is to determine in a society what is common about the common sense. What are our real shared societal values? What do we as a community agree upon is the right thing to do? That's the hard question. It's relatively easy to make things internally consistently logical. So to summarize, it's a lot easier in medical ethics to construct an ethical system which makes sense, that is, a system which is internally logical, than it is to construct an ethical system founded on true, common, shared societal values. Which brings us, in the COVID-19 controversy, to the classic problem of ethics. How do you allocate scarce resources if there's a limited number of ventilators, a limited amount of blood in the blood bank, a limited amount of space in the OR, a limited amount of vaccine? If there's only a certain number of seats in the lifeboat, who gets in and who gets left in the water? This lifeboat problem of medical ethics is not a hypothetical. It's not about the movies with someone yelling, "Women and children first." For example, in 1841, the commercial ship, the William Brown, sunk off the coast of Nova Scotia, and people were thrown overboard from the floundering lifeboats to die in the frozen North Atlantic. And the chief mate was brought to trial in Philadelphia over how he chose to allocate the scarce resource of seats in the lifeboat. With this as a backdrop, now we can turn our attention to the specific. Who decides where you get in line for the COVID-19? What are the principles upon which we do that? Well, the first principle of the allocation of scarce healthcare resources is that a physician has a duty to do all he or she can for the benefit of their patient. They are caring for a person. They're not serving the needs of the state. Decisions about the allocation of a scarce healthcare resource are made by social consensus vested in appropriate societal institutions, as long as those decisions are transparent, widely discussed, and subject to regular review. And we rely on four fundamental principles: the degree of benefit, the likelihood of benefit, the duration of benefit, and the extent of the benefit. Let's unpack those. The degree of benefit. If the mortality rate is higher in the elderly if they get COVID-19 than in children, then the elderly have a higher degree of benefit and should get the vaccine first. Likelihood of benefit? Assume you have two people who are in line to get blood from the blood bank, but there's a limited amount of blood. One is in hypovolemic shock, and the other has a hematocrit which they can live with, although it's low. You're obviously going to give the blood to the former, not the latter, because of the likelihood of benefit. Duration of benefit? You give scarce resources to people who are going to benefit from them longer than from people who are going to benefit from them for a shorter period of time. And very important, extent of benefit or magnitude of benefit. In COVID-19 vaccination, if you vaccinate a frontline healthcare worker taking care of COVID-19 patients in the ICU, then vaccinating her will not only benefit her, but the dozens and dozens of patients she will take care of. Contrast her to a hermit living in the woods who sees no one and talks to no one. There is very little magnitude of benefit. He benefits, but no one else does. So the ICU worker gets the vaccine before the hermit. What are not appropriate to use as principles and who gets the vaccine in what order? The ability to pay, the personal concept of social worth, and the past use of medical resources. Oh, look what you got in the past. You shouldn't get anything in the future. We as a society generally reject these concepts. So using the principles I've articulated, we create priority lists. Who's on group 1A, who's 1B, who's 1C, or in the British system, who's group 1 through 12 for the COVID-19 vaccine. That's how we decide who gets the vaccine in what order. And I will conclude with the wisdom of the idea of common sense and common values of how we do things in society with a teaching from the third president of the United States, Thomas Jefferson, who in a letter wrote, "I know of no safe depository of the ultimate power of society, but the people themselves. And if we think them not enlightened enough to exercise their control with a wholesome discretion, the remedy is not to take it from them, but to inform their discretion. Rely on the wisdom of the people, and you will find a common value and the common sense for medical ethics." Thank you for listening.
Hello, my name is Kathleen DiCaprio, and I'm an assistant professor of microbiology and immunology at Touro College of Osteopathic Medicine, the Harlem campus. Today, I will be addressing frequently asked questions about the COVID-19 vaccines. I have no conflicts of interest to declare. Now, in this presentation, I'll provide information on several of the more commonly asked questions regarding the two currently available vaccines, both of which are mRNA vaccines. Now, the Pfizer vaccine, which was the first to receive emergency use authorization in the United States, includes 2 doses separated about 21 days apart. And the Moderna vaccine, also 2 doses, they're spaced about 28 days apart. Now, both vaccines provide greater than 90% efficacy, as demonstrated in their phase 3 trials using this schedule. So let's jump into a couple of the questions. The first one, in the interval between the first and second vaccine, how much protection against the virus does a person have? Now, following the receipt of the first dose of either of the 2 currently available vaccines, it will take about 10 to 14 days to generate a good specific immune response against the vaccine, or against the virus, I'm sorry. At that point, most people should have at least some specific immunity to the virus. But the question is, how much? Now, the exact amount of protection provided by a single dose of either vaccine is not completely known. Now, efficacy data following a single dose of the Pfizer vaccine is still not fully known, but there is some data to show that a single dose could provide about 52% efficacy, but Pfizer still stands by, currently supporting a 2-dose regimen. Number 2, does it matter which vaccine a person gets? If I were to be asked which vaccine do I want, what should I say? I get this question a lot. At the moment, unfortunately, you probably won't have a choice which vaccine you're offered. It mostly depends on what your site has available. The vaccine rollout is tightly controlled and may be for quite some time here. Now, realistically, you're not going to be able to choose which vaccine you get, probably at least for several months, when other vaccines hopefully will receive emergency use authorization, hopefully, and when these existing vaccines increase their productions. Number 3, what do I need to know about allergic reactions? Now, it's important to recognize that any vaccine or medication has the potential to cause an allergic reaction. But as far as allergic reaction goes, the CDC currently recommends the following. Anyone who had a severe reaction to a COVID-19 vaccine should not get the second dose. People who have had a severe allergic reaction to any ingredient in a COVID-19 vaccine should avoid the vaccine formulation containing that ingredient. Now, both companies provide a list of all the ingredients of their vaccines if needed. Now, because allergic reactions can occur, the CDC has provided specific recommendations for post-vaccine observation. Number 4, eventually, will we be vaccinating children? If so, when? Is a big question. Yes. Studies of COVID-19 vaccines in children, they have started, but we just don't know when we're going to start vaccinating children. We have to wait for the data on those trials. Now, it's important to recognize that the Pfizer vaccine is actually approved for those as young as 16 and the Moderna vaccine as young as 18. Now, in September, Pfizer began their vaccine trials with children as young as 12, and Moderna followed suit in December. Now, if these trials yield good results, the companies will recruit younger children volunteers. The FDA will then have to review these results before the vaccines can get emergency authorization. Number 5, will COVID-19 be like the flu vaccine? Will I need to get vaccinated every year? Well, we still do not know yet. Receipt of the flu vaccine is annual due to these minor mutations as well as waning immune responses to the flu. Now, with COVID-19, we're still unsure about a few things. First, how long does the COVID-19 vaccines provide protection? And the rate and degree to which the SARS-CoV-2 virus mutates and how efficient the existing vaccines work against these existing variants. Now, it's possible that COVID-19 vaccines will become an annual event, just like the flu shot, or it may be that the benefits of the vaccine last longer than a year. We have to wait and see how durable the protection from the vaccines are. Now, immunity from natural COVID-19 infection or SARS-CoV-2 infection appears to last for months at least. So this may be a hint about the vaccines. The goal right now is to get as many people vaccinated as possible. So the next 6 months or so, we'll begin to see that 1-year data from those who started the early phase studies. So we'll start to see how long their antibodies have lasted. We'll learn as we go along. Number 6, everyone's talking about this virus mutating. Is there a chance that the vaccine will be ineffective because of these viral mutations? Great question. Now, although SARS-CoV-2 is constantly mutating, the prevailing view is that the mutations we're seeing in the virus should not compromise the effect of the vaccines. Now, many observations reveal that some of the more recent mutations, and these mutations are what create the variants of the virus, have made the virus more contagious. But more details and data are definitely needed. Now, these variants do not appear to make people sicker. And it's inferred that the vaccine should protect against these newer versions. So both Pfizer and Moderna are actively looking at this. In fact, recently, Pfizer released some data to strongly suggest that the antibody responses induced by their vaccines do neutralize the variants from the UK and South Africa. Number 7. If I've been vaccinated, can I still transmit the virus to someone else? Do vaccinated people need to continue to socially distance and wear masks? While there's surely encouraging and positive data showing that the current vaccines provide strong protections against COVID-19, there is still some details that we need to know about the types of protection and the strength of the protection the vaccines provide. For example, we don't completely know whether or how well the vaccine protects against asymptomatic spread. So as these data are explored all across the world, as the world is disseminating the vaccine, we need to continue to wear masks and socially distance to help control the spread. Now, in the next couple of months, it will surely be interesting as vaccine efforts continue across the globe and additional vaccines get ready to release phase 3 clinical trial data. In the meantime, stay tuned and stay safe. Thank you.
Hello, this is Dr. Edward Halpern, back to tell you about how to get your continuing medical education credit for today's program. The program offers up to 1.5 hours of CME credit, and there's 2 ways to get your CME credit. You can send a text message to 828-295-1144 and type in 92 BIKE, BIKE, 92 BIKE, all in capitals. And if you send that message to that phone number, you'll get a quick response with instructions as to how to get your CME credit and how to fill out your satisfaction questionnaire. If you don't like doing it that way, you can use your search engine, type in www.eeds.com, and up will pop our website. Click on the sign-in button. Once again, enter the code 92BIKE, and once again, you'll get instructions as to how to get your CME and how to fill out your satisfaction questionnaire. Now, these ways of getting your CME will be active until the end of the week, Friday, January 15th at 3 o'clock. So please write down these instructions or take a screenshot or take a picture with your cell phone so you can get your CME credit. Also remember, as the program continues today, if you have a question for any of our speakers, go to the question and answer function on your screen, type in your question, and we're monitoring them. And we will monitor them and parse them out to our speakers so they can answer as many of your questions as possible during the program. And now back to our program.
Good afternoon. I'm Karen Murray, the Associate Dean of Admission for the School of Medicine at New York Medical College. I'm also an assistant professor of the Department of OBGYN at New York Medical College. This afternoon, we're going to review the recommendations of the COVID-19 vaccine in pregnancy and lactation. I have no disclosures. The recommendations I'm going to present this afternoon are those of the Society of Maternal Fetal Medicine, as well as the American College of OBGYN. A conversation between the pregnant patient and her clinician is recommended by both societies. However, it is not required. The conversation should revolve around the acuity of the virus in the community, your personal risk of contracting COVID-19, the potential efficacy of the vaccine, the risk and potential severity of the maternal disease, including its effect on the fetus and the newborn, as well as the safety of the vaccine for the pregnant patient and her fetus. There are currently 2 vaccines that have emergency use authorization from the FDA. The Pfizer vaccine are for individuals who are 16 and over, and the Moderna vaccine are for individuals who are 18 and over. The efficacy of the COVID-19 vaccine in pregnancy is unknown. There's no data that's available for pregnancy, but it is likely to be similar to that of the non-pregnant adult. It's up to 95% effective once you've gotten both doses within the first weeks. It may prevent severe COVID-19 disease. However, the duration of protection is unknown. A pregnancy test is not required prior to the administration of the COVID-19 vaccine. There's no data on the timing of conception following vaccination. There is also no data on a trimester-specific vaccine consideration. The vaccines are mRNA vaccines, and they're not live virus vaccines. They do not enter the nucleus of the cell and do not alter the human DNA. The vaccine should not be given if the recipient is acutely ill. Some of the side effects of the vaccines are listed below. Both vaccines have similar side effects, with the most common being injection site reaction, followed by fatigue and headaches. Patients have also complained of having fevers following vaccinations. It's been shown that after the second dose, the side effects are slightly more common. If a pregnant patient develops a fever following vaccine administration, they should be administered acetaminophen. There is no preference as over one vaccine over the other. Patients who've had a vaccine in the last 14 days should not receive the COVID-19 vaccine. Also, if you've had the COVID-19 vaccine, you should delay subsequent vaccinations such as Tdap or influenza for 14 days. RhoGAM should not be withheld from patients who are planning to receive the COVID-19 vaccine. It's been shown that it does not interfere with the immune response of the vaccine. The CDC has a list of what they call high-risk medical conditions, and pregnancy is atop the list. If a pregnant patient does get infected with COVID-19, they can develop severe complications. Some of the risks leading to severe complications are older pregnant women, pre-existing medical condition, as well as Black or Latinx women. This is very similar to what we see in the general population. Hospitalized pregnant women with COVID-19 can develop severe illnesses. If they do develop a severe illness, they're at increased risk of ICU admissions, mechanical ventilations, as well as death. Slow the spread and protect yourself from COVID-19 during pregnancy. Wear a mask when you're out in public, stay 6 feet apart, wash your hands frequently, and continue to receive your prenatal care. Within the vaccine trials, there were no pregnant patients. However, there are a few patients who became pregnant after being part of the trial. So far, there are no reports of any problems with these pregnancies, and they're continuing to be monitored. Going forward, as pregnant women get vaccinated, the FDA will gather information about its safety and efficacy during pregnancy. The CDC has also developed a website called the V-Safe After Vaccine Health Checker. You should have your provider register you for this website, where you can be frequently monitored for symptoms immediately following vaccination. You can also self-report any side effects that you may have following vaccination. The benefits of getting COVID-19 vaccine are: it protects you from getting the disease. You must get both doses in order to be fully effective. It has not yet known whether or not you can still continue to pass the virus after you've been vaccinated. Vaccinated folks should still wear masks and practice social distancing. A safe vaccine is one in which the benefits of getting the vaccine outweighs the risk of having the disease. The only people older than 16 who should not get the vaccine are those who've had a severe allergic reaction to a vaccine in the past. If you're breastfeeding, you can still receive the COVID-19 vaccine. Do not delay or stop breastfeeding just because you get the vaccine. The theoretical risk of vaccinating the lactating woman does not outweigh the potential benefits the vaccine has to offer. If you choose not to get vaccinated while pregnant, you can get it after you've had your baby. Talk with your healthcare provider about a plan to get the vaccine after pregnancy. It is important that you continue to follow infection preventative steps, such as wearing a mask, washing your hands frequently, and maintaining social distancing. Here is the website from the CDC about with more information about the vaccines. Here is listed also the V-Safe After Vaccine Health Checker website. The CDC also has websites that are geared towards healthcare workers, where it talks about safety monitoring, as well as gives you the vaccine guidelines, the vaccine rollout guidelines. Thank you.
We hope you've been enjoying our plenary presentations. I want to remind you that the CME credit is provided for free, but it's not free for us to create this programming. So if you want to support programs like you're listening to and watching today, and our COVID-19 research projects like the ones mentioned, if you want to help defray our time, effort, and funds for doing this, please consider making a tax-deductible gift to New York Medical College, and your donation will help offset our costs. Great things are happening at New York Medical College, including today's webinar, and we hope you'll consider making a gift from one of the three options, phoning us at 914-594-27 2720 to make a gift to support the webinar, to go online at www.nymc.edu/give and making your gift online. Or if you'd like to write a good old-fashioned check, we'll be happy to cash it. Send it to New York Medical College, make it out to New York Medical College, and our address is New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of the college during these challenging times. Stay safe and healthy. And now let's turn our attention to the question and answer period. Remember, if you haven't typed your question in yet, go to the question function at the bottom of your screen on most of your screens, although for some of you it may be on the top. Questions, type your question in and we'll be monitoring them. And we'll read them and parse them out to our individual speakers. So now let me introduce Dr. Alan Kadish, the president of the Touro College and University System, to be our moderator for the question and answer part of our program. Dr. Kadish.
So we'll start with a very quick question for Dr. DiCaprio. Is the second dose of the Moderna and Pfizer vaccine the same as the first dose? There's been some talk potentially about using half doses. Where do things stand now and what are your recommendations?
Those are great questions and definitely questions to be concerned about. The vaccine doses are the same. So your first dose will be the same as your second. The recommendation is not to mix the brand. So a Pfizer vaccine, the first dose would be Pfizer, the second would still be Pfizer. So we're not mixing that. There has been discussion about changing the actual concentration of the dose. In other words, giving half a dose, because they're actively discussing that and probably enacting that in other parts of the world. In the United States, the recommendation by the FDA is to not do that. And they stand by that as of today. It could change, but their argument is just, and it makes sense because these doses at these concentrations with this schedule is what has been studied in phase 3 clinical trials. Changing any of that could change the outcome. These vaccines, as they are in this schedule, are 95% effective. If we change that, we don't know what the efficacy will be. And so the recommendation is to not do that. Thank you.
Thank you very much, Dr. DiCaprio. And now another question about vaccines to Dr. Montecalvo and perhaps Karen Murray. Do you recommend taking nonsteroidals or acetaminophen before taking the vaccine, particularly if you've had a mild reaction to vaccines or the first vaccine in the past? So that's to Dr. Montecalvo.
I would not recommend taking it before the vaccine. It's true that, 70, 80, 90% of people will have arm soreness. But you can certainly take acetaminophen after the vaccine if you have any symptoms, but I wouldn't recommend doing it beforehand. And I also think it's important to be careful to monitor your symptoms post-vaccination. As has already been spoken about, it's very important to register any side effects. So, I would only take acetaminophen if I really needed it.
Thank you. And Dr. Murray, would you answer anything differently during pregnancy about taking either acetaminophen or nonsteroidals, particularly if you do develop symptoms?
Thank you for the question, Dr. Kadish. No, I agree wholeheartedly with my colleague, Dr. Montecalvo. It is not recommended to pre-medicate prior to taking the vaccine, but to take acetaminophen if you do develop symptoms after being vaccinated.
Okay, and one other related question to pregnancy and vaccines. Are there any data about any possible effects of either COVID infection or the vaccine on future fertility, understanding that it's early and there may not be, but is there anything that you've heard?
Thank you again. Right now, there's a paucity of information about COVID-19 and pregnancy. So really, we haven't seen any data to support that there is an effect on fertility if you've had the disease. We do know that in the vaccine trials, they did do, the trials that were done on the animal models did not show any effect on fertility. So at this point in time, we know the vaccine has not shown any effect on fertility, but we really don't know the information about the disease itself.
That's great. Thank you very much. That's encouraging. Let's switch gears away from the details of vaccines for a moment, and then we'll come back to it perhaps a bit later. Professor Cashton talked about the power of the state to require a person to be vaccinated. Can you comment on the power of an employer to require vaccination on the part of their employees? And do you think that's something that should be done?
Thank you, Dr. Kadish. It is unlikely, I think, at this point that a private company or an employer will mandate a vaccine, though it is certainly within their right to do so. Predominantly, it's unlikely because this would be quite unpopular from a legal and potentially cultural perspective. There would be a significant amount of backlash. So within their rights, but unlikely to do so at this time.
So let me throw an additional question to you, which relates to one of the questions that I've been asked. We do know, for example, that K through 12 educational institutions and colleges and universities actually do have vaccine requirements. You can be exempted in certain situations. So with the same comment you made about employers, do you think that that's also appropriate for educational institutions? Or is there a different sort of communal risk when you're dealing with other students that would change that paradigm?
So it's possible that a waiver might be insisted upon, and that employers would highly encourage vaccination versus mandating it. So waiver possibility in that kind of situation.
Great. Thank you very much.
Thank you.
Another question about vaccine prioritization for Dr. Halpern. You talked a little bit about who gets the vaccine first within a community. What about global issues? Which countries get the vaccine first? Do some countries have more access than others? And what should that be based on?
There is unfortunately no vaccine for selfishness. And a problem that we face is people individually saying me, and voters and the public telling their politicians, us first. So one would argue that if my tax dollars went to create a vaccine and a vaccine infrastructure, that my country should get it before somebody else because they're, quote, a freeloader, and they are benefiting from my tax dollars producing an infrastructure to produce a vaccine. Your sense of altruism would say that we ought to treat all people equally and that they all ought to share. There is also a self-interest argument on the part of rich countries, which is if we don't distribute the vaccine to poor countries, it creates a reservoir of infection, which will extend to us. My view on the question is the questioner is exactly right. In the same way as individuals say me, countries say me, and tend to take care of their own before they take care of others. And that is a form of self-interest or selfishness.
So if you were running a country, would you feel that the obligation that you described to citizens of the world would mean that you should be sure that everyone, not your own citizens, whom you perhaps have a different level of obligation to, would get the vaccine equally?
If I ran a country, I would support the creation of robust World Health Organizations to create an international system of disease management, as opposed to the current president who penalized and tried to withdraw from the World Health Organization. And so if I ran a country, I would understand who votes for me and who doesn't vote for me and support my own citizens, but I would, as a citizen of the world, support international organizations to have an equitable distribution of healthcare resources.
Thank you, Dr. Halpern. So there are a whole series of questions for me right now. So the first is the notice sent out by New York State about education workers. And who's eligible. In particular, it's a question by employees of Touro and New York Medical College, are we eligible? So right now, forgetting about the healthcare piece, and of course, there are healthcare workers at both Touro and New York Medical College. Our best understanding as of today from New York State, and the announcements and guidelines change every day, but our best understanding is those employees who have direct contact with students in in-person classes qualify for an enhanced priority to receive the vaccine in 1B, and those workers for colleges or universities or medical schools who contact students or have the same priority as K through 12 teachers who are in Class 1B in the priority part of Class 1B in New York State, meaning that they're currently eligible to sign up. Right now, employees who do not have direct contact with students or who are working remotely do not yet qualify as specific education employees, as opposed to the next categorization, which is essential employees, where employees of colleges and universities would qualify. So it's a rapidly evolving situation, but the ones who are available to sign up today are those people who come in direct contact with students, because that's a situation which can enhance the spread of the virus, and therefore it's a priority to avoid infection and transmission among those people. The next question that I was asked was, is Touro going to require that students, faculty, or staff be vaccinated before starting on-site classes? I tried to get Professor Cashton to answer that question, but at the end of the day, we're considering what the options are and trying to balance individual rights versus societal need. We're certainly going to strongly encourage vaccination. Whether we'll absolutely require it, except for waivers, is something that's still being discussed. There's a question of what on-site precautions we're taking to protect against the new highly contagious variants. Right now, Touro and New York Medical College have substantial remote presence in education, obviously not in healthcare, but in education. And we're scrupulously adhering to isolation in every possible way. Quite frankly, there's not much more we can do with the new variants short of removing those experiences which are now in person. And as I mentioned, those are very limited. They're limited to the direct healthcare setting, to certain laboratories that are very difficult to do remotely, and to a few classes where students really felt that they wanted to be on the ground. So short of closing on the ground activities completely, there's not much more we can do. So we're not planning to change anything in regard to the new variants. There's a question about offering testing for students, faculty, and staff, and we currently have a variety of different testing programs in place to sample infection rates in all our facilities. We'll continue to do that and continue to refer people in the Westchester campus to the family medicine clinic, in other campuses, to affiliates that we have for testing if individual testing and individual care is needed. And finally, are we offering remote learning options for all our in-person experiences? And the answer is, at the present time, we're doing that as much as possible. Going forward in the future, we'll continue to do that as long as there's a high risk of infection and transmission. When exactly we're going to return to more in-person classes really depends, as it does, I think, for everybody who's looking at this, with what happens with COVID as we go forward. So we continue to have a flexible response at Touro and New York Medical College. It's rapidly changing because the epidemiology of the coronavirus now, as I've shown you, at record levels, will hopefully get under control. Okay, let's now return to some additional questions about vaccines, which of course are the issue of the day. So Dr. Montecalvo, the next question is for you. The specific question is about someone who lost sense of smell, but the real question is, if you develop COVID early after the first dose, and there have been many reports of people developing COVID in the first 7 days after receiving the first dose of the vaccine, should I still get the second dose of the vaccine? And what are your thoughts about that?
Yes, thank you for the question. Yes, you do complete the vaccination series, providing that you're not still on isolation at the point, or that you're not still sick at the point of the second dose. We will have people who are incubating COVID and don't know it at the time that they receive their first dose, but with an incubation period that is, at most 14 days. Anyone who is going to become symptomatic will, and you should have resolution of the disease before you would be due for your next dose. And so, yes, the current recommendations are to proceed.
So thank you for that. And this is really a question both for you, and I wanted to get Dr. DiCaprio to weigh in as well. What's the time window around which the vaccine can be administered? We know that the recommendations are 21 days for Pfizer and 28 days for Moderna, but do we have any information about whether there's any flexibility in that time window? And particularly if you have to be on isolation or for whatever reason you can't get the vaccine, do we know over what time frame it still is effective to get the second dose, either before or after the recommended 21 or 28 days?
Right. So CDC, they do want you to stick to the exact date, but they do allow a window of 4 days, and that's information that's available on the CDC website.
Got it. Do we know if that recommendation is data-based, or is that simply because they want to get as close to the clinical trial as possible? In other words, do we have any data about people where it hasn't been given exactly at the right time?
Not from the data that were submitted to the FDA from the phase 3 trials, from the briefing documents. So I don't know.
Got it. Okay, Dr. DiCaprio, some people have talked a little bit about side effects from the vaccines. There have been perhaps a couple of extremely serious side effects reported. You talked a little bit about allergic reactions. There have been some other rare side effects reported. Is your sense at this point that those are real and that there should be an area of concern? And how should we think about those rare but serious side effects that have been reported?
Yeah, those rare and serious side effects are definitely ones that, you could see that concern people for sure. What we know now is that the majority of the side effects are mainly fever, joint pain, definitely arm soreness, very typical of any vaccine. A few things that we do see on occasion is from the trials, there were a couple of cases of Bell's palsy, both the Pfizer vaccine and the Moderna vaccine. So those are definitely side effects that we are looking out for, and we're hoping that if anyone experiences those, they will report those side effects. High fever we're seeing in some patients, especially now that patients have started to receive the second dose. A little bit more arm soreness, that's a big one. Now, some of these rare, I know that, if you Google things, we're all Googling things these days, right? Cardiovascular events like a heart attack. There are a couple of reports of a patient or two across the globe experiencing heart attacks. But from what I can gather is they've all been Pfizer, FDA, and the associated health departments of those countries had said that those events were unlikely linked to the vaccines because of the time frame in which the vaccine was given, just minutes or slightly, very short period of time following that, and given the underlying health conditions of those patients. But we are looking at those. It should be just pointed out that anaphylaxis and allergic reactions are the #1 side effects that we're looking for, because those will happen very quickly following the administration of the vaccine. And so those are our biggest concern right now. Thank you.
Sure, thank you. I will say that one of the challenges we have in evaluating side effects to vaccines is the issue that you raised, Dr. DiCaprio, are cardiovascular events occurring after the vaccine related to the vaccine. The fact is, we do know that acute stress can cause plaque rupture. So of the hundreds of thousands and millions of people who received the vaccine, some of whom had cardiovascular disease, it's possible that in some indirect way, stress of getting to the vaccine administration sites, particularly if it's cold weather, and the entire psychological aspect, which we've talked about the COVID pandemic, could potentially trigger something. But it's certainly not anything that can be controlled or anything, as Dr. DiCaprio says, that seems to be directly related to the components of the vaccine. And that stress could happen anytime. And as I've said, I think by now millions of people worldwide have had the vaccine, and cardiovascular effects are common in relation to a variety of things. Let's return to Dr. Murray for a second. You may have mentioned this, but we had specifically had a question. Do you have any concerns about any of the antibody cocktails in pregnancy? I think you said you probably didn't, but do we have any data about that? And is there any reason to think that the antibody cocktails might be a problem in pregnancy?
Thank you for the question, Dr. Kadish. I think I will just rely on what my colleague, Dr. Montecalvo, said early in her presentation, that the published reports that we did have on the antibodies, we only had one arm of the 4 arms that showed any benefits. So with pregnancy right now, we like to be a little bit more, since we have no real data and it's all, it's just kind of, we're kind of trying to derive the information based on the non-pregnant patient. We're still recommended that the best treatment for COVID-19 is to not get infected. So, we would not recommend right now a cocktail of antibodies because we don't really know what the effects of the antibodies would be in pregnancy. So I'll side with Dr. Montecalvo on that one. And there's no research right now that's available or out there about data on pregnancy and antibody cocktails for COVID-19.
So let me now ask perhaps Dr. DiCaprio, Dr. Montecalvo, or you, a kind of practical question. We've all heard the recommendations that even after getting the vaccine, you should exercise social distancing. You should continue to wear a mask. There is a theoretical possibility, from what I understand, of the virus incubating, even though someone who's gotten the vaccine may not be at high risk of infection. The question that I'd like the 3 of you to weigh in on is, so how careful do we need to be? Let's say it's someone who hasn't seen their family in months, now has been vaccinated, has received the second vaccine. It's a week or 2 after the second vaccine dose. Is that risk such that they should continue isolating from their family? Or is it reasonable to say that the protection of the vaccine and the risk of transmission, if you've gotten it, is low enough that you think we can relax those restrictions?
Thank you. As I presented in the slides earlier, we are still unsure of whether or not you can still continue to transmit the virus even after you've been vaccinated. The data for that is still unknown. So my recommendation would be to still continue wearing a mask and social distancing even after you've been vaccinated.
Right, but so perhaps Dr. Montecalvo and Dr. DiCaprio can weigh in. So I'm not suggesting that people don't wear a mask, but there's some people who've intentionally not seen people in their family because of the concern about infecting them. So in addition to social distancing and mask wearing, should we continue to actually completely isolate, let's say, from older relatives, or is the risk low enough that you think we can potentially relax some of those restrictions if we continue to wear masks?
So,
2 of you can weigh.
yeah, so I think there's 2 issues, and I agree with what Dr. Murray just said. So first of all, I think we have to remember that this vaccine is under emergency use authorization, and that means that although its efficacy is 95%, which is extraordinary, it means that only 50% of the people who received the vaccine had to be followed for 2 months before the emergency use authorization was granted. So those cohorts from Moderna and from Pfizer are going to be followed for a full 2 years. And we really don't know about efficacy further out and the duration of efficacy. And that's the reason why the public health measures don't just go away with this highly efficacious vaccine, that we really have to wait and be very patient through this process. In response to your specific scenario, Dr. Kadish, of should I visit my family who I haven't seen, I think that someone can visit their family safely. You can, you can get a diagnostic test, make sure that you're COVID negative, make sure that you are scrupulous before you visit your family, and that allows for a safe visitation. But the having been vaccinated doesn't change that right now. That we have to learn more about the duration of the efficacy.
Great. All right, thank you very much. That's been very helpful. So one last question. Someone asked, who was listening to one of the early seminars, said a speaker at one of the early seminars said it would take years to develop a vaccine. How did we get it so wrong? And I'll just take a quick shot at that because time is short. Typically, throughout history, it's taken 5 to 10 years to develop vaccines. Two things have changed. One is there's been an extraordinary effort on the part of the worldwide scientific community to develop a COVID vaccine. Different groups of scientists and different companies that theoretically are competitors have collaborated in ways we've never seen before, and enormous resources have been put into developing these vaccines. And in addition, the science has just gotten a lot better. And the combination of those two things has been one of the few successes that we've had on the public health sphere in dealing with COVID. And we're really hoping that with the advances that you heard described today from our speakers about vaccines, with the way we're distributing them, hopefully more ethically, that will really make a difference in dampening the spread of the coronavirus and helping end this pandemic. So thanks to our speakers for telling us how we can do this, and thanks to the audience for listening. Stay healthy, follow the recommendations, and have a good afternoon.